Now, February was Black History Month, and I wanted to add a historical coda that might be of interest. Race is not a major contributor to mental illness per se, at least it shouldn't be, and that's because scientific research has not identified any biologic or genetic factors that associate race with susceptibility to mental disorders. Therefore, any variations that we find in population frequencies between racial groups are most likely due to environmental factors, so-called social determinants of health. For example, poverty, poor nutrition, drug abuse, trauma, crime can be environmental risk factors for mental disorders. Other possible factors can include things like education or prejudice. And this is illustrated by the historical example of such occurrences I want to share with you. In 1843, the United States government conducted a census which, for the first time, included questions that were designed to measure the frequency of brain disorders in the population. Now, at the time, there was so little understanding of brain disorders that there was no compendium of illnesses like which exists now, such as the DSM or the ICD, the International Classification of Disease. Therefore, the census takers had only two choices to indicate whether there was a mental disorder or an intellectual disability, and the names were not in the most politically correct fashion: insanity and idiocy. All the different mental and what we now know as developmental disorders or intellectual disabilities were lumped into these two broad categories. And the census takers were given no instructions or no criteria describing the conditions to guide them in making these decisions. So when the census takers went house to house to collect the data, they were left to their own devices as to what constituted a mental disability. And these decisions were easily susceptible to cultural biases or even outright racism. And the results, unfortunately, reflected this. In reviewing these data, the American Statistical Association were shocked, and they communicated their concerns about the veracity and plausibility of the data to Congress. Quote, many towns had all of the colored population indicated to be insane. And in other towns, there were markedly varying but implausible proportions that were ascribed to each category. 2/3 of the people, 1/3 of the people, quarter of the people, half of the people, more than is plausible. And even more outrageous was the fact that these results were used by some people to defend slavery. Data where the rates of idiocy and insanity of African Americans in northern states were higher than in southern states were cherry-picked. And advocates used them to indicate that maybe slavery had mental health benefits. Subsequently, it was determined that the inflated rates of idiocy and insanity were largely due to the educational differences, meaning many African Americans had not gone to much school, didn't understand the questions, and were not articulate enough to be able to answer in a way that met the expectations of the census takers. And so this confusing or lack of response was construed as evidence of being insane or an idiot. Now, I'd like to think that such influences of ignorance and prejudice don't affect psychiatric diagnosis and treatment in our present mental health care system. But however, there is some evidence that they do. Black patients presenting in emergency departments or clinics are more likely to receive a diagnosis of schizophrenia than an affective psychosis, or be treated with a generic psychotropic medication instead of a newer drug that may still be under patent protection. It's also the case that Black populations are suspicious of institutional authority and often reluctant to access mental health care from traditional providers. Now, this leads to undertreatment and greater suffering of people in minority communities. Now, clearly, we can do better, and we're trying, but there's still a gap to be closed. We need to provide more proactive outreach and innovative and more engaging ways for underserved communities to access clinical care and obtain quality mental health services. But more about what those ways are for another time. So for now, This has been Dr. Jeffrey Lieberman for Shrink Speak with another Shrink Short.